to today's webinar. So to the French people, I'm just going to address you in French, just to make sure that the language translation is okay. So bonjour à vous et encore merci à tous les participants venant des pays francophones. Je tenais à vous dire encore merci de nous rejoindre ce week-end. Et j'aimerais vous dire qu'il y a la traduction. Si vous cliquez sur l'icône où c'est écrit Show Caption, où il y a le CC, vous serez capable d'avoir les sous-titres en français. Encore merci et nous espérons que vous aurez encore une belle session aujourd'hui. Merci. OK, we can start.
Thank you, Dr. Flory, and hello all. Welcome to our fifth session, From Farm to Bedside. Of course, this week our focus is on this critical topic of the safety, risk, and contraindication of medical cannabis. To guide us through this important discussion, we are honored to have a distinguished expert with us today. She is not new to you. You have seen her since the beginning of this program when we spoke about when we introduced the general phytomedicine. And then when we introduced the cultivation of cannabis and its best practices, you saw her when we spoke about chemistry, extraction, and preclinical use of medicinal cannabis. And last week, she was also here when we spoke about clinical application of medical cannabis. Please join me in welcoming Dr. Sandra Carrillo, a medical doctor and a professor from the University of Columbia. Dr. Carrillo specializes in cannabis science and the clinical application of CBD and THC for patient care. She's passionate about healthcare, innovation, advancing cannabis research and education. Dr. Sandra, the floor is yours.
Thank you so much, Billy. Thank you, Dr. Fleury. And I'm very pleased to be here with my esteemed colleague, Dr. Jordan Tischler. We share a very special passion for academic education since we both are part of the Association of Cannabinoid Specialists. I am board member and he is the president. So this is going to be a very interesting conversation today. Thank you, Billy, for all the introductions that you did about me. I have a master's in health services administration and also certified in research epidemiology, among many other certifications. And today we will be talking about safety and side effects of cannabinoids. I always like to start talking that cannabinoids or cannabis is being used for many years. This is a medicine that is being used by our ancestors, and it's a millenary medicine. We have reports of the uses of cannabis since 2,700 years before Christ. It was widely used in Chinese medicine in Orient, and it was until 1839 the Irish Dr. William O'Shaughnessy brought the uses of cannabis to America and to other continents after he observed the way they were using it in Asia. We have reports in different pharmacopoeias about the use of cannabinoids in different type of ailments. It was reported to be used for edema, gout, cough, and a lot of evidence was built around the uses of cannabinoids and cannabis. Sadly, in 1937, the Marijuana Tax Act was implemented along with the prohibition. And this, as you may know, was happened due to many different reasons. Among of these reasons were like a racial, commercial, not related with health outcomes particularly. The good news is scientists from all over the world were interested in the potential of the plant of cannabis, and this is why Professor Rafael Meshulam, for example, a pioneer in this area, discovered or isolated in 1964 the molecule of THC among many other discoveries that he did, and we owe him so much in terms of research. I had the opportunity to be with him in the Jerusalem University, learning from him, and also other scientists. In 1988, Aline Howlett and William Devane, they discovered the CB1 receptor, and after this, a lot of discoveries have been released in the world, and many countries are right now studying and doing a lot of research about cannabinoid medicines. Also, a lot of countries have been legalizing medical cannabis all over the world. Right now, there is 53 countries that legalize medical cannabis around the world. As you see in here, by the 20th century, more than 100 papers were published in medical journals, and the cannabis was sold over the counter. But the cannabis, the prohibition kind of stopped all this. But now, since the last 20 years, there is a very big amount of research that is being released and that is ongoing, trying to elucidate the many other potential that the cannabis plant has, and also studying in depth the modulation of the endocannabinoid system that is very interesting. It's important to know, when we're going to talk about side effects, that there are three different categories of cannabinoids. The endocannabinoids are the ones that our own body produced. The phytocannabinoids, they are the ones that are present in the plants, and not just the plant of cannabis has cannabinoids. We're going to be talking about the cannabis plant particularly, and the synthetic cannabinoids, that they are the ones produced in the laboratory. Many of you already know what is the endocannabinoid system. It's very important to know that it's a system that is in charge of the homeostasis of the body, and is responsible for many important functions. It's composed by receptors. The most studied receptors are CB1 and CB2, but there's many other receptors that interact in the endocannabinoid system. This is composed too by ligands or endocannabinoids that, as I mentioned, are the molecules that our own body produce. The most studied ones are anandamide and 2-HG. I'm not going to stop in depth about this because you already saw the theory of the endocannabinoid system, but it's important to know that these ligands or endocannabinoids, they interact with the receptors such as CB1 receptor, and in a special manner, and by interacting in the way that a lock and a key interact, they produce a lot of different therapeutic actions. And it is here where the phytocannabinoids of the plant of cannabis, they're coming and mimetizing the endocannabinoids. They go and have an union with these receptors. It's the case, for example, the THC, as you see, interacts directly with the CB1 receptor in a similar manner where the endocannabinoids, they're doing it. So they are performing different type of actions. The endocannabinoid system is a very important retrograde signaling system, and due to this important retrograde signaling is that we obtain a lot of the benefits. As you see here more in depth, besides the receptors of the endocannabinoid system and the endocannabinoids, we also have enzymes that they are in charge of synthesizing and degrading the endocannabinoids. And this is the the way where they are produced, and they are produced at demand. And this is a very important mechanism. And we see in here not just the endocannabinoids interacting, in this case with the CB1 receptor, also the THC and also the synthetic THC such as dronabinol. The plant of cannabis, as you may know, and you know already because we saw it in other modules, is a very complete, but it's a very complex plant because it has more than 1,500 compounds. The more important ones are the cannabinoids. Cannabinoids, they have isolated already more than 120. The most studied cannabinoids are CBD and THC, but as you see in this graphic, there is others. There are acidic forms, barinic forms. There is the CBG, the CBN. Also, the plant of cannabis has terpenes, terpenoids, that they also have therapeutic actions, and they have flavonoids, which is a very important field of research right now. I have seen, and we saw in module 2, Dr. Sayida from Harvard showing the promissory research they're doing with some cannabinoids, and also we know Dr. Will has done very impressive research with flavonoids in the context of cancer. As I mentioned, the most studied cannabinoids is CBD and THC. Sorry for the typo there, CBD. And they both have different type of effects, and they have different molecular targets. THC, as a partial agonist of CB1 and CB2 receptors, has a lot of properties as an anti-inflammatory, anti-emetic, anti-spasmodic, among many other therapeutic properties. And CBD has multiple therapeutic sites or targets. It's a very novel molecule, but it's a very promiscuous molecule. And as you see in here, it could be agonist of the receptors of serotonin, 5-HT1A, agonist of the receptors of glycine, modulators of calcium channels, agonist of the vanilloid receptors, allosteric modulator of opioid receptors, a modulator of the system GABA and glutamate, antagonist of the GPR55, and so on. And I'm showing you this because by seeing what type of receptors these cannabinoids are targeting or can affect, is that you see the variety of the therapeutic action that these cannabinoids can exert in the body. As I said, CBD is a very novel molecule, but cannot be trivialized. Sometimes they're selling in gas stations, and as you see in this graphic, CBD acts in many and numerous different types of therapeutic targets. So we see that it can have a lot of properties, but it has to be used under medical supervision, because as it produces all these effects, it also could produce side effects if it's not used by a doctor or physician or healthcare professional that knows where are these receptors that the CBD impacts. We see in here, as I mentioned, the only receptors that interact with the phytocannabinoids or with the endocannabinoids is not just CB1 and CB2. We have the TRVPs, the GPRs, and it's very important this because when you see the therapeutic effects, you also see the side effects, and usually the side effects are dose dependent in the major part of the times. It's important to know that the cannabinoids, they have a first phase metabolism and they grow to the cytochrome P450. These enzymes are involved in the first phase of the cannabinoids, and they have second phase, mainly carried out by transferases. It's important to know that there is some genetic polymorphisms that the patients can have that could affect certain cytochromes, the CYP2C9, 2C19, and 2D9. They may significantly alter the speed of metabolism of cannabinoids. This is something that is important to have it in mind. So when we're talking about safety, it's important to know what is the evidence that we have around safety. This is a publication they did in the European Journal of Internal Medicine, where they're talking about the epidemiological characteristics, safety and efficacy of medical cannabis in the elderly. We know the elderly, they are populations that they are very sensible to different conditions with medication. So in this study, the average of the patients, they were between 65 and 74 years old. So they were assessing what were the side effects that these patients that they were undergoing to treatment with cannabis for different pathologies. After 6 months, they evaluated this group of patients and they asked what were the side effects that they were displaying or reporting. And the majority of the side effects were very minor. 9% reported dizziness, 7% dry mouth, and 3% somnolence. And when you see the rest of the side effects, they are very little percentages. And in these populations, only 10% stop cannabis due to adverse events and ineffectiveness. It's very important to consider that there is the risk of falls, falling with the elderly. And in this study, they realized when they did the survey to the patients, the 53% they were reporting falls prior to cannabis initiation. So it's not always the cannabis that want to be fault for the falls, but they reported that 21% reported falls following cannabis treatment. So this is a situation where, as physicians, we need to be aware that there is a risk of falls because sometimes the cannabinoids can cause hypotension, orthostatic hypotension. So we have to tell the patients what to expect and how to manage this situation in order for them not to get injured. Also, in this study, they evaluated something that I consider that is a very important property that the cannabinoids have over many other medications, and is the reduction of the polypharmacy. In the clinical practice, we usually get patients that they come in taking 2, 3, or 4 medications. And in this study, they are referring that the patients that were using cannabinoids, they were able to reduce the polypharmacy. Particularly, they're talking that they were able to reduce opioid analgesic, other analgesic drugs, benzodiazepines. And when I show this, it doesn't mean when a patient comes to the clinical practice taking an opioid, we immediately are going to stop the opioid and start cannabinoids, because that's not the way we do it in the clinical practice. We have to go through a process of reduction. There is actually protocols for reducing the opioid dosing and implementing the therapeutic with cannabinoids. It's very well established. Same with benzodiazepines. You have to start reducing little by little the benzodiazepines in order to start the cannabinoids, but this will always have to be a multidisciplinary approach. If it's a patient that is being treated with the psychiatrist, this reduction has to be done in alliance with the psychiatrist or with the neurologist or with the oncologist. So, because what we want is the best for the patient. Talking about safety, this is a very famous study that it was called the COMPASS study, and it was the largest prospective study on long-term safety of medical cannabis use by patients with chronic pain. These were patients with chronic non-cancer pain for more than 6 months. And the result in this study, it was that they didn't have increase of serious adverse events versus the control. And no difference in cognitive function, biochemistry, or hematology. This is what they reported in this study. And they reported a significant improvement in their levels of pain, symptom distress, mood, and quality of life. We're going to see the one also of the other advantages of using cannabinoid therapies with the patients is the improvement in the quality of life. And this may sound subjective, but we have in the clinical practice special scales and questionnaires that we can apply to the patients since the very first moment they comes to the clinical practice, and we can measure the quality of life after 6 months, after 3 months, and that way we can see how these patients improve. Mainly, the cannabis can produce adverse events, of course, because as every other medication produces, but the majority of times these are very minor. The most common, as I showed you in the other study, was drowsiness, fatigue, dizziness, dry mouth, sometimes anxiety, nausea, or cognitive effects that they are more moderated. But the majority of these side effects that they are more unpleasant are due to the THC. Let's remember the THC is the one that causes euphoria, intoxication, but usually these adverse events are dose dependent. So when we are in the context of the clinical practice, we start with the smallest doses, and we start doing the titration up little by little. We never start with high doses because we will have high side effects or adverse events. So we start with slow, and as they say, start low, go slow, but it's very important personalize the treatment because it depends what type of patient we have in front. So we will decide how we start this titration. It's a very well-known this that the combine CBD with THC to reduce the THC related adverse events. But recently it was published this study that it's a motivation for reevaluating some of the concepts, although this study has a very small sample of patients. And what they were trying to see if the cannabidiol reduced the adverse effects of cannabis in schizophrenia. And this was a randomized double-blind crossover trial. Particularly what they wanted to do, these were patients that they have schizophrenia, but they have cannabis use disorder. So they were using cannabis, and in this cannabis use disorder, what they use mainly is THC. So what they were trying to see is if by giving them a pre-treatment with CBD pills to these patients, it will ameliorate the effects of the THC. They gave them 1,000 milligrams to a group, and the other group they gave them placebo to see if the CBD was able to reduce the impairment on this or the side effects that the THC produced. And the conclusion in this study was that the CBD did not attenuate the acute effects of cannabis on memory impairment of psychotic symptoms. So this is very new. There is a wide conversation saying that the use of CBD can ameliorate the side effects of THC, but this was just published recently, so I want to leave it there for everybody to analyze it too. Cannabis safety, this is an old graphic, but in 2011, the CDC reported 480,000 deaths due to use of tobacco 26,000 due to alcohol, 16,000 for prescription medicines, 4,600 for cocaine, 4,300 heroin, and zero for cannabis. It's very important to know that there is some reported deaths that they are attributing it to cannabis, but when they re-study the case and what happened, usually these patients or they were using other substances with the cannabis. So it wasn't just the cannabis, it was the other substances, the one that caused death. Regarding to more adverse effects, it is important to know that in the case of CBD, the side effects are very mild. Again, it could have a dry mouth, but regarding to the most common adverse events, 20% will be in the nervous system, 13% gastrointestinal, and 12% respiratory disorders. In this case, when they did this study, they were evaluating also patients that they were smoking. Let's remember that smoking is not a therapeutic alternative. As doctors, we don't tell the patient to smoke. If we need the inhaled route, what we tell the patient is to use special devices, that they are medical devices, that they use the flower. But smoking in the clinical practice, we don't recommend the patient to smoke. Some of the other adverse events that they found was somnolence, amnesia, nausea, dizziness, euphoric mood. Sometimes, as I said, you can say this is an adverse event, but in patients in the context of palliative care at the end of life, to have an euphoric mood is not that bad. They can benefit from that. But there is also patients that they are old adults. Sometimes they come and they say, I don't want to be intoxicated. I don't want to feel high. So this is a very customized treatment. So it's depending on the needs of the patients that you decide what type of treatment you give them. It's important to know the cannabis shares similar side effect profiles with other medications. For example, opioids, sedative, hypnotics, alcohol, benzodiazepines. As a side effect, they can produce sedation. Well, cannabis can produce sedation too, so they can be potentiated the effect. This doesn't mean that you have to be afraid or that it's contraindicated to use cannabis and any of these substances together. What you need to do is to remain cognizant that this happens, and that way you will titrate the dosing, and you will reduce one medication or reduce the other medication. Same thing happens with the other anticholinergics or atropine, that they produce tachycardia, drowsiness, dry mouth, same like cannabis, and in this case THC could happen. So the important thing is to know that these interactions and that these profiles of side effects that they share with other medications exist, so you will know how to moderate the dosing. Regarding to toxicity, this is very important because, as we see in here, the ratio or fatal dose to effective dose of cannabis is very, very wide. As you see here, heroin is very narrow, and that's why it's so dangerous. And in this publication that it was done by Health Canada, there is an important publication that they did for healthcare professionals. They say that there has been no documented evidence of death exclusively attributable to cannabis overdose to date. As I mentioned, what they found was that the people was using other substances, and then the lethalities were caused. And they state that they're using rodent LD50 values for oral administration, the equivalent of a lethal dose of THC in humans, has been extrapolated to more than 15,000 milligrams. This is an amount that is almost impossible to consume. So in here, we know that there is a molecule when we're talking about safety, when we see this toxicity, the amount that you have to consume is extremely high. It's very important that the THC overdose can produce dose-dependent, unwanted, and potentially significant mental and physical effects, typically dizziness, sedation, euphoria, cognitive impairment, dry mouth, hypotension, increased heart rate. But it's been demonstrated that the adverse events are generally tolerable in the healthy adults and not in other patients that they are taking another medications. In the Marinol monograph, as you know, Marinol is a THC synthetic produced in a laboratory. They say that when a patient comes to the clinical or to the emergency room with an intoxication, it has to be treated. And they have a recommendation protocol and what to do with these patients. Regarding to CBD, overdose and toxicity, they found that CBD LD50 values after a single IV dose of CBD were 50 milligrams per kilogram, what is the equivalent of 285 milligrams in mice. And there were no deaths in rats and monkeys given daily oral doses of 25 to 300 milligrams per kilogram of CBD for 90 days. We have a lot of studies that they were done by GW Pharmaceuticals, now Just Pharmaceuticals, and the studies, that some of them were done by Orin Devinsky et al., where they were given the pediatric populations between 25 and 50 milligrams per kilogram per day of CBD without having overdose or toxicity. Of course, when they are using the higher the dose, more side effects or adverse events were reported. And in these cases, 79% of patients report side effects, but most often of them, they were mild or moderated, and they were transient. Serious adverse events, possibly related to CBD use, were recorded in these studies of Devinsky in 20 patients. It's important to know that most drug interactions are associated with concurrent use of depressant of the central nervous system, such as alcohol, hypnotics, when you use them among with cannabis. And it's important to know too, the cannabis has effects on the bioavailability of substances, as you see in this graphic. I'm not gonna stop in here, but as I said, they are substances, they are increased by THC, for example, alcohol and warfarin, and this is one, when we have a patient that is using warfarin, we have to be careful with THC, and we have to be measuring the INR to see the coagulation panels, because interferes, and some professionals say that you shouldn't use it when you're using THC, or when you're using warfarin, you shouldn't use THC. And there is some that they say that you can use it, but very cautious and monitoring very closely the coagulation panels for the patients. And you see there are substances, they are increased by CBD. And one of the examples that we see a lot is when the patients are using clobazam, mainly in the studies of Devinsky, they're using clobazam in the patients with refractory epilepsy. And there is a very clear interaction when you use clobazam and CBD, the metabolite of clobazam and desmethylclobazam is increased, and the patients start having more side effects. The situation in here is not that we have to be afraid of using clobazam and cannabidiol. What we have to do is to know that this interaction exists, so we reduce the dosing of clobazam under certain protocols and monitoring the patients. And this is the opposite case. There is substances that are affecting the cannabis bioavailability. For example, there is substances that increase the bioavailability of THC. We have as example the omeprazole, the verapamil, the ketoconazole, and there is also substances that decrease the bioavailability of THC and CBD. So we have to be aware of this when we are giving cannabinoid therapy to the patients, because there will be other factors that they could be interfering. And I want to highlight in here the ones that decrease the bioavailability as St. John's wort. In the clinical practice, we have to ask the patient not just what medications are you taking, you have to ask them about supplements, because sometimes patients don't tell you about supplements or vitamins, and definitely we need to know everything that the patient is taking, because it could be possible drug-drug interactions, as there is with the other rest of the medicines that we use in the clinical practice. In here, this was a publication of the American College of Physicians in 2020, where they were talking basically about the effects they can cause the cannabinoids, particularly THC, due to the effect that they have in the receptor CB1 and CB2, which are located in the central nervous system and in the periphery. And the high THC amounts can produce relaxation, anxiolysis, euphoria, altered perception, and increase of appetite. In here, again, we're reporting this like a side effect or adverse effect, but the increase of the appetite is something that we use in the clinical practice a lot. On the benefit of the patients that they have cachexia, or the patients that they are palliative care, that they don't want to eat due to chemotherapy, because also helps them with the nausea and vomiting. It's a reality that the potency of the THC has been increasing over the past 20 years. And this is why the College of Physicians is trying to raise awareness among the clinicians and the population, because 20 years ago, the potency of THC that you could find was around 4%. Now, due to the hybridization of these cannabis plants, the potency of the plants is not 4%, it's 20 to 30% of THC. So they've been finding more visits to the emergency room and more in the use, non-medical use setting. They are having all these side effects. So it's important to know that when a patient has intoxication or takes too much THC, there is a non-pharmacologic treatment and a pharmacologic treatment. And no pharmacologic is just have the patient in a quiet place with supportive care, keep the patient hydrating, monitoring the vital signs, and do like reassurance to the patients, tell the patient that it's going to pass. So the patient, because sometimes they come with a panic attack, anxiety attack, they come with tachycardia, and they are extremely nervous due to the high amounts of THC that they take. And There is a pharmacological approach. This is in the when you have the in the emergency room that you see these patients. You can also give the patient sedative hypnotics such as clonazepam, lorazepam, or if the patient is in a psychotic state, you can use antipsychotics. Definitely in the context of prescription of medical cannabis, as we see as clinicians, it's very rare to have a patient to have intoxication or overdose, because what we do is we do a very careful titration. We choose different types of cannabinoids. We do a titration with a small dosing. So when we do this, we don't face this situation. This is more in the context of the non-medical setting or the adult or recreational use. The signs of intoxication, as you may know, it could be a conjunctival injection, redness, orthostatic hypotension, increased heart rate, palpitations, and all the cognitive consequences that we know that the acute use of high amounts of THC can cause. And there is psychiatric complications, moderate and severe. Such as moderate could be impaired memory, disorganized thought process, but when the patient comes into the emergency room with these situations, what we can offer is what I show you in the past slide: the reassurance, the hydration, have the patient knowing that this will pass. Another side effects that we've been facing or that is been increasing is the hyperemesis syndrome, and this is due to the use, particularly again, of high amounts of THC. Although Dr. Ethan Russo, a very famous neurologist, published a paper where he was showing that this cannabinoid hyperemesis syndrome, it could be also due to a special genetic mutation of a patient, that they are more prone to develop this hyperemesis syndrome. And in this case, the patients have a lot of vomiting, nausea, stomach ache. It's a very unpleasant situation, and sometimes take a few days to be resolved. You can implement therapeutic for the patient with some sedatives, with some antiemetics for the breakthrough nausea, and the patient reports that taking excessive number of hot showers make them feel better. But definitely it's very refractory and very unpleasant for the patient. Regarding to safety, the American College of Physicians recommends to do screening to the patients to try to identify if the patient will be or start developing cannabis use disorder. And we just do simple questions like if the patient is using more cannabinoids of what they intend, if they have difficulty reducing their use, or if the use of cannabinoids is interfering with their activities, health, or social commitments. So there is also some screening, brief inventory and referral to treatment, special tools that they are created precisely to identify if the patient has cannabis use disorder. Let's remember that the cannabis use disorder now is typified in the DMS-5. So we have to be aware that the patients can have this, but in the clinical context, it's very rare that the patients develop this cannabis use disorder. But as physicians, we have the obligation to be monitoring the patients. If we are doing a personalized treatment to the patient, if we do the follow-up, if we do the proper titration, is rare rare that this happens, but we have to keep it in our minds. This is a very recent publication where they're talking about the update on cannabidiol clinical toxicity and adverse events. It's a systematic review where they were checking about the reports of CBD toxicity and adverse events. They included 51 reports, and the conclusions were that CBD was well tolerated with very few serious adverse events, mainly when the largest doses of CBD are used in patients, pediatric populations with refractory epilepsy, but that there is important to monitorize the drug-drug interactions, as I mentioned, with the clobazam, with valproic acid in these patients in pediatric populations. But they say that they need more studies that they will show the long-term effects and interactions. And these last publications about cannabinoid toxicity, they were more focused about the toxicity of synthetic cannabinoids like K2 and spikes, that they were widely abused, and they are representing a very high risk of mortality. So very important to remain cognizant that this is happening, and that this diagnostic will be based on the clinical response of the patients, and the treatment will be in a special center with the special considerations and interdisciplinary collaboration. So I will finish with this last study, that it was a pharmacovigilance study published last year, where they were saying that this is the first real world safety description, where there were patients that using cannabinoids based medicines, and the most affected system were the nervous system, central nervous system, and gastrointestinal system. In the most reported symptoms were dizziness and somnolence. So I want to leave you with this cannabis risk populations, a special risk, as you see. And for if somebody wants to learn more about these subjects, I collaborated in these two books, and I've been able to go all over the world learning in different continents and helping different governments to legalize cannabinoid medicines in favor of safe access through prescription for the patients. And I want to leave you with this phrase: nothing in life should be feared, only understood. Now is the time to understand more, to fear less. Thank you so much. And now I leave the floor to my esteemed colleague, Dr. Jordan Tischler.
Welcome, Dr. Jordan.
Wow, that was fantastic. Thank you, Dr. Carrillo. That was very comprehensive. Let's see if I can get my slides to come up now. There's that. All right. So as Dr. Carrillo left things, we're going to talk about risks and special groups. A lot of what I'm going to say, she's already begun the conversation for us. So that is fantastic. Before I get into the meat of my discussion, there were a few things that I wanted to address, in light of what Dr. Carrillo had said. And one of the thoughts I had when I was listening to her talk about the side effects of THC was, well, why would we want to use THC at all if it's got all of these side effects? And in fact, it does have some significant side effects, as she's mentioned, in terms of intoxication, dry mouth, and the risk for, or at least the association with psychosis. But of course, the THC really is also the medication that we have the longest research on, going back over 70 years. and really does provide us with the majority of the medicinal benefit as well in terms of the things that she mentioned: pain management, sleep management, mood management, nausea and vomiting, anorexia, those sorts of things. So I just wanted to kind of point out that we don't want to shy away from the THC simply because, like all medicines, it has a bunch of side effects. The other comment she made, which is very, very common amongst, in the cannabis world, is this advice to start low and go slow. And of course, that is very good advice generally for all medications. But what's lacking in the cannabis space, which is more clear in the sort of conventional pharmaceutical space, is, well, okay, but once we start going up, sort of, is there an upper limit? And the answer is yes, but very little discussion about that. And so I would say, look, it's perfectly reasonable to start at a low dose, which typically is kind of in the 5 milligrams of THC range, but also that we want to think that once we get up to about 20 milligrams of THC per dose, that we're unlikely to see better benefit, and we're going to start to see more complications like the side effects that we've been talking about, as well as the increased risk of accelerating tolerance and dependence. And that's, of course, what we really want to stay away from. The other comment as an ER doctor is that, in the study from Dr. Hill, there was some mention about treating patients in the emergency room with acute overdose with pharmacologic agents like benzodiazepines and various antipsychotics. And while that is certainly possible, I would not advise that in the least, that adding other medications, unless this situation is very extreme, is going to lead to polypharmacy that you're going to have to deal with as time progresses. And that, in fact, in most cases, the sort of understated non-pharmacologic approaches of, they called it reassurance, but I think that going beyond that, if you can have family members or even a practice assistant sit with that patient and sort of continue to talk to them and to kind of bring them back towards reality, then we let the metabolism take its course, and that, generally speaking, leads to a better outcome over some period of time. So those were my initial thoughts. Now let us talk a little bit about those specific risks and what to think about them. So we're going to talk about pediatrics right now. And, the discussion around pediatrics sort of starts with the concerns for brain development. As you no doubt are aware, our best estimates are that kind of on average, people's brains develop up until about the age of 25. I think that that's kind of an average number, and certainly there's some variation on either side of that. We have seen numerous studies over the years looking at MRIs of teenagers versus non-users, or earlier versions of themselves and after this commencement of use kind of stuff, which will show changes on those MRIs. Typically cortical thickening, particularly in the frontal and prefrontal areas, as well as thinning of the hippocampus. And then we've got the functional MRI studies that seem to show increased metabolic activity in the frontal and prefrontal areas. And why is this behaving badly? So, the question we have to ask, right, is, well, we can see these changes on these studies, but what does it really mean? I like to sort of jokingly say, well, these changes could be bad, or we could be making X-Men, and this is the next step in evolution. I'm not saying that seriously, but I does want to point out that the assumption that changes on an MRI are not necessarily bad unless we can demonstrate that they change something in terms of behavior or development and that sort of thing. When we look at IQ studies, which it says, as mentioned earlier, because the slide comes from another talk, what we can show is that we can find about an 8-point drop in verbal memory skill, but no changes in spatial or quantitative reasoning. This is in adults who started as teenagers and have been using technically high doses meaning at the time that they started the study, and now these doses seem much smaller. But over 30 years, we can start to see these kinds of small decrements in the specific verbal memory area. So what does this really mean, and what do we advise our patients about? Well, there's a series of studies that have been started and actually run by American researchers on a population of young recreational cannabis users, or then young, starting in 1970 and still continue to be ongoing at this point. You can see that here it was most recently published again in 2019. This is kind of called the New Zealand study. And the interesting part for me is that it followed kind of real world trajectories of these users. Again, these are non-medical. These are people who are using it recreationally. And what they found is that over the course of a lifetime, these people do not seem to fall off their expected life trajectories, meaning it doesn't lead them to not complete their education. It doesn't lead them to be unable to get and maintain employment. It doesn't lead to their being unable to develop important social relationships. And so I think that ultimately that is a fairly reassuring phenomenon. We do have to recognize, though, that teens in particular and young adults, meaning less than 25, have some additional specific risk, which maybe includes psychosis. We'll talk about that in a second. But it certainly includes increased risk of dependence. The average figure for adults seems to be somewhere in the 7 to 9% range. But when we look at under 25, those numbers are higher at about 18%. And just for comparison, that 18% is about the same as we see for benzodiazepines and actually cocaine as well. So when we're talking about treating a teen or young adult, we need to be extra cautious and be very, very specific about what we are recommending to our patients, both in terms of the dose, number of milligrams, and the frequency, how many times a day are we recommending. And we want to keep both of these as low as possible, just as we would with any other medication. We want to monitor their use as closely as we can. In the state of Massachusetts, where I am based, we have the benefit of being able to see through our prescribing portal what it is that the patient is actually purchasing. And actually, I'm able to set a very broad limitation on how much they can purchase. In other jurisdictions in the United States, there is none of that. Which is very problematic. And in other countries, particularly throughout Latin America and Israel, for example, it's done with an actual prescription. So you can be very specific about this. And so I had noticed that earlier in the comments that somebody had asked about different jurisdictions. This is a hugely important difference, and the answers and the approaches to doing this safely are going to vary by how the government there has set up the process. When we're talking about younger people, particularly the teenagers, it's just a really good idea to have the parents involved, and they should administer and maintain control over the medication so that we don't have, 15 or 16-year-olds sort of with free access to these medications. And as Dr. Carrillo mentioned, there are some circumstances in which various forms of inhalation are important therapeutically, and hopefully you've kind of talked about that in other parts of the course. But we also have to recognize that inhalation, in addition to some risk to the lungs, which is a modifiable risk, we have to acknowledge that the bigger issue is that inhalation can be done without a lot of thought, meaning people can kind of just sort of sit there and puff away on whatever that object device is, and they may in fact end up inhaling a much larger dose than they expect and that you would recommend to them. And because of the mindlessness of it, it can go from reasonable to unreasonable fairly easily. So that you may be telling somebody, I want you to take 2 puffs on your flower vaporizer, and then you see them again 6 months, and they say, I'm doing just what you told me. I'm taking 4 puffs on my vaporizer. And you say, wait a minute, I said 2 puffs. And they go, oh, and then, you try to reel them back in, and then 6 months after that, you see them and they're up to 5 or 6 puffs. And so you really have to keep track of that. And it's certainly with teenagers who are going to be even less attuned to their own risk, this is a major issue. And so I would avoid inhalation as much as therapeutically possible in that particular group. The take-home message here is, we see these changes on these various structural studies and functional studies, but we really don't know whether they're lasting or meaningful, and therefore we have to assume that there's some risk there, and that we should be cautious about using cannabis at all in a young and otherwise healthy teenager, but in teenagers with sort of advanced illnesses, say epilepsy or uncontrolled anxiety or things like that, then we may use it, but we should use it in a very cautious manner and with the supervision of their adults. Now we'll change to the other end of the spectrum and talk about older people. And Dr. Carrillo talked a little bit about this. So one question is, how does age influence cannabinoid treatment? And interestingly enough, in terms of the physiology, it doesn't seem that age makes that much difference. And in fact, things like height and weight or BMI and even renal function don't seem to be directly relevant to outcomes. There is significant risk, as she talked about, amongst cardiac and pulmonary patients. And that's something that we need to talk about, but I don't think we're talking about in detail today. There's no evidence that older patients have more cognitive dysfunction than from the THC than younger people. Not mentioned here, there are now a number of studies, primarily from Dr. Gruber's outfit out at McLean Hospital, that have shown that in mostly elderly, but in general with patients who come in for treatment with cannabinoid medicine, that their cognitive function actually improves, largely because now we are developing that quality of life, and that we are ameliorating the symptoms of whatever the underlying illness was, or and that in fact the patients are cognitively impaired by their illness, such that the impairment from cannabis is still a net benefit, and that in fact on the balance their cognitive function is better treated with the cannabinoids than untreated with their illness. It's also very important to understand that despite all of that, many older patients are very concerned about their cognitive function. It's always interesting to me that the older people are much more concerned about their cognitive function, whereas it's the youngest people who have the greatest risk, but less concern. And in this case, then, if we are not supportive to our patients, they may become so fearful of the intoxication and those cognitive changes that they do not tolerate them and will not proceed with the treatment that otherwise could increase their quality of life. So as Dr. Carrillo pointed out, there have been a bunch of studies that look at falls, and that there certainly is some risk for elderly folks falling down. But in general, the sum of the studies show that patients pre-cannabis risk of falls is about what you'd expect in their post-cannabis use of a risk of falls, and that the cannabis itself is not contributing to their falls. Furthermore, we have to understand that most of the cannabis programs are so focused on the safety of minors that it's often very difficult for elders to deal with the tamper-proof packaging. If we want them to use cannabis by vaporization, they may have difficulty grinding the cannabis flower and loading the machine or seeing the screen. And so we, again, just need to be kind of cognizant of those issues that are more potentially problematic for older patients. So Dr. Carrillo did a wonderful job of talking about drug interactions. I will sort of summarize this but not belabor it. The bottom line here is that we know that through the mechanisms that Dr. Carrillo talked about, both CBD and THC can potentially interact with a wide range of medications, some of which are potentially problematic. This slide is a slide that represents the medications that people were searching on Google to find out about cannabis interactions. And in the chart here, what we're looking for are these red Ys, which means that there is a definitive known interaction. So here we have CBD that interacts with esomeprazole, which is a proton pump inhibitor. And generally speaking, esomeprazole is a very benign medication. So if we modify its blood level by adding CBD, that's not really a big problem. You can see that there are also some black teas in here, which are theoretical interactions, but not ones that we see in the real world, or not yet have seen in the real world. This slide, on the other hand, are the medications that I was concerned about, not so much the populace in their Google. And you can see that, unfortunately, there are far more red Ys, and most of these things were on Dr. Carrillo's slide as well. But I mean, the interactions here are with much more dangerous medications. Amiodarone is a cardiac regulator, which again is helpful in its correct dose range, but if we elevate the dose, it can become quite dangerous. Everolimus and its cousin down below, tacrolimus, are anti-rejection drugs that, if again, are toxic at high levels and at lower levels will be ineffective and potentially lead to the loss of the transplanted organ. There are a bunch of others she mentioned, warfarin, and so those are things that we really need to be careful about. The one that makes me lose sleep most of all is loratadine. Loratadine, at least in the United States, and I imagine in most other places, is an over-the-counter antihistamine that, unfortunately, if you actually overdose on it, can cause very challenging cardiac dysrhythmias that can be fatal and very difficult to treat in the emergency setting, and CBD can interact with that. And so we now have two substances that are sort of freely available in our societies without any real warning that could potentially lead to lethal combination. We haven't seen this play out yet. However, part of the problem is there's not a lot of surveillance going on at this point, so that if people were having these problems, it's not clear that we would be picking it up. On the THC side, there are far fewer directly applicable, but tacrolimus is one where both CBD and THC are concerns. Let's circle back into the mental health aspect of things. The risks for issues around mental health are multiple. We know, for example, that the dosing of cannabis is tremendously important, and that at low doses we can generate benefits, but at high or uncontrolled dosing, we start to develop some tolerance. And as that tolerance increases, it can, number one, continue or start to escalate on its own, meaning people need more and more of the THC. And essentially, this defines dependence, which is that you need more, and that if you stop, you get withdrawal symptoms. And then in the worst case scenarios, we can develop what's defined as cannabis use disorder, or CUD. We'll talk more about that in a moment, but that is sort of, unfortunately, a mixture of physiologic and behavioral aspects that can come together. The other aspect that is really challenging is that if we're using cannabis for anxiety or depression to influence mood, we have to understand that it is a double-edged sword, meaning a little bit can be helpful, but a lot can make things worse. And if we go and ask people in the community, how do you use cannabis to treat anxiety and depression? They will often say, well, you just keep smoking, and whenever you feel bad, you smoke some more. And what we know is that that's actually worse, because while they may feel better in the moment when they use it, that long-term high dose, particularly daytime use of cannabis can actually exacerbate anxiety and depression. And so you can get into a vicious cycle where they feel anxious, they use some cannabis, they feel better briefly, but then the things get worse, and then they keep using cannabis and making things worse. And so we may need to actually intervene in that scenario to break that cycle and to get them on lower doses that can be more effective as well as safer. Timing of the dosing is tremendously important. Daytime use has been shown to decrease work and school performance, but again, also worsening of anxiety and depression. There is, we think, some potential risk associated with cannabis and psychosis. I will have a couple of slides on that I want to get to in a second. And then we also want to talk a little bit about cannabis use disorder and its potential for misdiagnosis. So let us talk about psychosis first. The problem here is that we have 20, 30 years worth of studies looking for the risk of causing psychosis. And we've seen a whole bunch of studies, just a few of which are listed here, showing an association of cannabis use and the onset of psychosis. So that association is real, but the question is it causative? We have also a whole bunch of studies that show no association of cannabis use and the onset of psychosis. And so what we really have here in the setting of these associations is the chicken and egg problem. Are people using cannabis and developing psychosis because of it, or are they mentally ill and developing a psychosis and then self-medicating with cannabis? And we have to remember that most people who start using cannabis are doing so, unfortunately, sort of in their later teens and early 20s, and that's about the time when psychoses rear their ugly heads, even without cannabis. So there is a very difficult proposition there, and I think the jury remains out on that. There are some studies which I think are interesting, showing that there may be particular genotypes which are at higher risk of developing the psychosis outcome, but these studies have not now yet translated into something that we can use clinically by doing a genetic study to give counsel to our patients. So that's kind of coming, I think. And then there are a number of twin studies, which I think are probably the most reassuring, in which what we've seen is that in the studies where one twin is using and the other is not, we can see that that there is some increase, for example, in psychoticism of psychotic flavors of behavior amongst cannabis users, but not compared to their non-using twin, meaning that it's something about them and not the cannabis. And again, in the lower study, the higher using twin seemed to have more evidence of cannabis use disorder, but no increase in the risk of psychosis. So all that boils down to, we've looked at a bunch of studies that that have used different methodologies to try to tease out an answer here. And at the end of the day, I would say there isn't a clear answer. And therefore, we need to be pretty careful about our use of these medications in patients who have already psychotic disorders, which includes not just schizophrenia, but bipolar mania, and probably best to avoid the use of those substances on those conditions, but also to be careful about patients who don't clearly have those conditions, excuse me, but have family histories suggestive that this could be an issue. I mentioned that there is cannabis use disorder as defined by the DSM-5, and that I think that there are some problems with this. We have to acknowledge that these definitions were developed at a time when nobody was really contemplating cannabis as a medication, and so any cannabis use was viewed as recreational at best and problematic most typically. And so we have these criteria that are important or are part of this definition. And the very first one, which of course is one that is often overlooked, is significant impairment of function and distress. So if a patient comes in and they say, I'm using cannabis and it's great and everything's fine, then we're hard pressed to find the distress that would then be necessary to define them as having cannabis use disorder. However, leaving that aside, there are also some criteria that are applicable to anybody who is using cannabis as a medicine, and frankly would be applicable to anybody using anything, any medication. So for example, spending a large amount of time getting your medicine. Okay, well, you know, if you're worried that you might not have access to the medicine when you run out, then you could say, oh, yes, I have that. Similarly, anybody who is using cannabis for a long period of time at least has the risk of some withdrawal or at least recrudescence of their underlying symptoms. And so this number 11 may actually tick positive for a cannabis patient as well. And we need to remember that only 2 need to be positive for the definition of mild cannabis use disorder. There have been, you know, when we are talking about the evaluation of an individual patient, it's easy for us as clinicians to think this through and to see whether it really applies. Where this becomes more problematic is when the definition of cannabis use disorder is used in research protocols where there's more strict adherence to these criteria, and it's very easy to overdiagnose cannabis use disorder, particularly amongst our cannabis therapeutic patients. So I just want you guys to be aware of those issues. Pardon me for just a moment. Now let's talk about pregnancy, breastfeeding, and fertility risks. So we're covering all the special groups here. The endocannabinoid system, as Dr. Carrillo had pointed out, is a homeostatic system that exists throughout our body. It's clearly involved in neurologic tissue. It's clearly involved in immunologic tissue, but it is also involved in all of our major organ systems as well. And the endocannabinoid system has been shown to play a key role in the implantation, possibly in fertilization, and also in cell migration during development. Cannabinoids, including THC and CBD, will readily cross the placental barrier, as well as being concentrated in breast milk. When we look at the studies around perinatal outcomes, the literature is very unclear. There continue to be new studies. There continue to be meta-analyses. There was one actually from last week that looked kind of grim. What we have seen is that birth weights are typically lower, but not lower enough or not low enough to fit into our current models of subsequent physiologic and developmental consequences. There have been a lot of studies that have looked at cognitive and behavioral outcomes in early adolescence, but these studies are deeply confounded by the ensuing, 10, 12, 15 years of maturation since birth. And so these, I think, are generally unreliable and not very predictive. The original study from the 1980s done by Dr. Dreyer looked at outcomes of offspring of cannabis-using mothers compared to non-using mothers in Jamaica. That study found no differences. Subsequent studies have looked at birth weight, as I mentioned, gestational age, APGAR scores, fetal and infant mortality. And as mentioned, only the birth weight has really been robustly associated with cannabis use. Although there are other studies that have found decrements in any or all of those measures. Fertility is another issue. Preconception studies of women who use cannabis have really shown no difference in fertility or viability or infant outcomes compared with non-users. On the male side of things, semen analysis of cannabis users have shown a whole bunch of changes, including decreased numbers of sperm, decreased sperm motility, and some very bizarre sperm morphology, including sperm with multiple tails and multiple heads, which have led to significant concerns for fertility in the male population. However, overall, real-world fertility of cannabis users compared to non-users tends to show no difference in terms of viable birth or live births. And so what this means to me as a clinician is, particularly on the male side of things, is if a couple is trying to get pregnant and they're having difficulty, then by protocol or standard, obviously we're going to do a semen analysis, and if we find that there is male factor issues there, then that's that point at which I would say, let's get you off the cannabis and see in 2-3 months whether the sperm look more numerous and more regular. One of the things that is problematic is that despite the fact that we have a lot of data that's concerning but not conclusive about the risks of using cannabis during gestation, in the real world, there have been studies now that show that not only are women advising each other to use cannabis during this period of time where we might not recommend that, but the sales people we call bud tenders here in the United States, are in fact recommending that they do use it. And so a study listed here from 2018 demonstrated that in Colorado, up to 60% of the salespeople were saying to pregnant women that they should use cannabis for treatment of nausea and vomiting and sleep and all these other things. And that's very much concerning given what we know at this point. So the current evidence recommendation from ACOG, the American College of Obstetrics and Gynecology, which is echoed by the Association of Cannabinoid Specialists, which, as Dr. Carrillo mentioned, we both run, is essentially, given the conflicting data on the effects of cannabis on fetal neurodevelopment and subsequent cognitive outcomes, women should be encouraged to discontinue use during pregnancy for both medical and recreational, in favor of other approaches that have more clear risks and outcomes. And that, I think, is probably, in light of the data, the most rational approach. So this is what I tell my patients at this point. For women, I tell them they should stop using cannabis about 3 months before attempting conception. In women who were not planning their pregnancy but find themselves pregnant and intend to carry that pregnancy to term, then I would recommend that they stop using cannabis immediately. And as I mentioned earlier, males should stop using cannabis if they might meet criteria for difficulty with conception or if the semen analysis is abnormal. And I just want to take 2 seconds to tell you a moment about the Association of Cannabinoid Specialists. This is an international organization of healthcare professionals focused on cannabinoid medicine. I like to think of it as focused on education for clinicians like we're doing today, as well as education for policymakers and lawmakers to help us develop systems of prescription and dispensing that more directly support patient care. And you can find us on the web at www.cannaspecialist.org. and we'd welcome your participation. And right now, membership is sort of pay what you can. So hopefully, finances would not stand in the way of anybody's joining the education and participating in our educational events and coursework. And I do believe that that is, yep, my last slide. So thank you all for your attention today.
Thank you so much, Dr. Jordan and Dr. Carrillo. Dr. Jordan is not only the founder and president of the Association of Cannabinoid Specialists, he is also a CEO of Med and is a medical doctor and leading cannabinoid specialist dedicated to elevating the standard of care for patients. He is also committed to education, where he continues to mentor PhD candidates and resident trainees for his clinic. Thank you so much, both of you, Dr. Carrillo and Dr. Jordan. Welcome, Dr. Brillin. And I'll start by asking, we have very few minutes. I'll start by asking a question that has been posted. And it goes like, are there risks associated with synthetic cannabinoids or unregulated products? And how are these addressed in patients' education?
That's a tremendous question and probably could be at least an hour's worth of discussion on its own. The nice thing about the THC CBD molecule, the backbone of it, is that it is readily extensible, meaning you can do all kinds of interesting things to it chemically that change its outcome. And so Dr. Carrillo mentioned K2 and spice, which are cannabinoids that are very highly psychotogenic and addictive, and really have no medical value whatsoever. And if you think about the three-ring structure, and then there's a little tail off the side, those things are created by adding methyl groups on that tail, and that creates that very potent outcome. There are so, you know, those cannabinoids need to be regulated sort of out of existence or out of use. There are a whole bunch of other problems that stem from the desire to take something that is legal, like CBD, right, and chemically convert it into intoxicating chemicals like Delta 8 or Delta 7 or Delta 10 THC. There are a bunch of other chemicals called HHC. And the point I made about the molecule is that the list of those cannabinoids that can be synthesized is basically endless. And there will be a continual process of taking CBD as the starting material and transforming it into all kinds of other things that are not known, right? They're new molecules we've never seen before. We don't know anything about their safety. And they're not illegal per se because they are unregulated. And then on top of that, because they're unregulated, they're often produced in ways that may have a lot of contamination associated with heavy metals or other byproducts of the synthesis reaction. And so at least in my practice at this point, I tell my patients that I have confidence in the safety of cannabis medicines that are legal through the state regulatory system because of the testing, and that anything that comes from outside that, again, here in the United States, typically things that are derived from hemp, those things I think we know are really quite dangerous. And due to the lack of regulation, particularly, and the novelness of those cannabinoids. And so I just tell my patients, do not go there under any circumstance, and, you know, stick within the state legal system where we have the confidence based on those testing protocols.
The second question will go to Dr. Carrillo. What role do terpenes and minor cannabinoids play in the safety profile and therapeutic outcome?
Oh, that's a great question. There is, we know, I mean, we've been studying, and there is a lot of studies about CBD, THC, right? The main cannabinoids. There is a lot of ongoing studies about other called minor cannabinoids, for example, CBG and CBC and the acidic forms and the varinic forms. There is ongoing research, but still we don't have like the rigorosity of the evidence that we need in order to apply it in the clinical setting, as we have, for example, as Dr. Tischler mentioned, we have robust evidence to use patients with spasticity and multiple sclerosis with a combination of CBD and THC. We have randomized placebo-controlled trials, systematic reviews. Again, we have two robust evidence with treating refractory epilepsy with cannabidiol, CBD Purify, or even a preparation that is CBD predominant, randomized placebo-controlled trials. Same with chronic pain, mainly neuropathic pain with preparations of CBD, THC, with again the rigorosity of the gold standard of the research and publishing in very reputable journals. And we started seeing publications, for example, with CBG for using in anxiety or THCV, but still we don't have the rigorosity of the studies that we have with these other pathologies. And as physicians, we have this obligation with the patient that safety first, do not harm, and to treat our patients based on scientific evidence. That doesn't mean the minor cannabinoids are not going to be applicable and valuable in the future for therapeutic purposes, but if we are guided by the scientific evidence, we still need to weigh again. There is like evidence with insomnia, with anxiety, but we've been studying mainly the cannabinoids as CBD and THC in different combinations, very robust. Terpenes are very interesting and they have their own properties that terpenes are terpenoids, and they are actually some groups studying the particular therapeutic actions of certain terpenes for treating certain ailments. But again, we still don't have that robust evidence that we have with epilepsy, with multiple sclerosis, with chronic pain, and for sure we're going to have it. But if we are clinicians that we want to treat our patients, the first thing that we're going to see is to treat them with the treatments, sorry for the redundancy, that they have better and more robust and solid evidence. Also, I like to talk about the real world evidence, that is what we've been gathering in our clinical practices with our own patients. There is a lot of doctors that have been using other cannabinoids in their clinical practice with good results, but we still need to understand that like randomized controlled trials are the gold standard. And I will leave it at discretion, because I hear colleagues saying, oh, I've been treating a lot of patients with CBG for anxiety and it's great. And remember, we all have the responsibility with our patients, and it depends how this physician feels with applying a treatment when the evidence is still ongoing, which I think the potential of the study of terpenes is amazing, and we see with the minor cannabinoids, I'm seeing amazing results, preliminary results with the acidic forms, with the varinic forms, particularly THCV, CBG, a lot of very good studies. But I think we still need more studies, but I am very excited to see the potential of these minor cannabinoids and the terpenes they have.
I see our time is up, but we won't be doing justice if I don't ask these two questions. Are there any disparities in access to safety, clinical supervised cannabis treatment, especially in marginalized or rural communities? The second one, what ethical considerations arise when recommending cannabis in settings with limited follow-up and monitoring infrastructure? Anybody can answer.
I think that at the moment, in my experience, how do I put this? The disparities are overwhelming, but not necessarily limited to sort of traditionally marginalized groups. That is to say, there are so few clinicians at this point who are both knowledgeable and willing to take care of patients using these medications that there's just a tremendous lack of availability overall, and that there's more access to the medication than there is to the knowledge. And as we've been talking about risks and dosing and education, we can clearly see that access to the medicine without the guidance can be really problematic. And so this is part of the reason why we're doing things like we're doing today, and why the Association of Cannabinoid Specialists exists, because right now we've got access to substances that are, helpful, but also potentially harmful, and people are doing it willy-nilly. I would say that in the United States, where we have unfortunately developed a very robust industry that wants to convince people, whether using it therapeutically or non-therapeutically, to use it in excess and to create sales, that there is a very strong problem with the messaging that people are getting around the safety of cannabis and cannabinoids, that can really only be countered by more of us being involved in their care and their education. And I think that right now we're losing because the industry has a lot of money and we generally don't.
Okay,
Yeah,
can you?
But I just wanted to add something.
Okay, Prof. Then Dr.
Sure.
Carrero will comment on
Yeah.
it.
Sure.
Okay. Yeah. Yeah. I think it's just then important for us to understand that cannabis actually comes from indigenous knowledge systems, right? And when you study these communities, they actually have guardrails of how it should be used. So I'm not really sure about in the cannabis space. I'm not sure if you can talk about marginalized people. And in fact, I think the sad thing that's happening is that the holders of knowledge, like if you think about Rastafarians in the West Indies, or certain communities, like I can give you an example in Zimbabwe, for instance. There's a community which is called the Binga community. I've just come back from Lesotho, where people have very deep roots of using cannabis and actually understand it. But what we find sometimes is the pharmaceuticalization of this medicine. This knowledge is, in a sense, being lost. And I think it's important that we maybe try to also dip into the tradition of the use of cannabis. Thank you.
Yes, thank you so much. I will have to say that I have a very special anecdote that something happened to me. I was speaking at a conference like 8 years ago in Colombia. And when I finished my lecture, a shaman from the community approached to me and he says, "Doctor, I like what you're saying about the way you implement it in the clinical practice, the application. I'm the shaman in my community. I've been applying cannabinoids, giving cannabis to all my patients, but I would like you to come with me to our community. I invite you because I would like to merge that knowledge, the ancestral knowledge that they have in the communities with the updated knowledge that you have. And I found that so nice, because it's not like believing that what they're doing in the communities is right, is wrong, or what we're doing in the medical practice is wrong. It's just like merging and trying to learn from each other, from the experiences that each of us we have, and combining all these on behalf of the patients. And definitely I think the marginalized communities, I think the impairment of the lack of access is to education, as Jordan is saying. And this is what I love to be part of the International Phytomedicines Institute and of the Global Health Catalyst, because as the name says, catalyzing win-win collaborations and try to eliminate disparities. And one of the disparities that we're finding in here is in education. So this platform is like a dream that we had for so many years, because as all of you know, it's going to be translated in Spanish, in French, in English, and in Portuguese. So the way to try to spread access to education. And I hope that in every community, in every corner that they have internet, they are able to have access to this education, because this is what we're doing. And we call it for free, right? But it is in order for all the communities, the people that don't have the means to pay for $20,000 program of a master's in cannabinoid medicine, they can access to good knowledge curated by key opinion leaders. And this is the way to start rolling the wheel, because these persons, they will get interested, they will see an opportunity for the clinical practice, for business, for helping the patients, and they will keep studying. So I think with this program we're gonna help to reduce those disparities in education with cannabinoid medicine. Thank you for that question. That was Stanley, right?
Yeah. So,
Yeah.
sorry, Dr. Belinga, can I just add to what has been said? Thank you so much to Dr. Sandra and Dr. Jordan. Dr. Jordan mentioned about vaporization, like a person will take 2 puffs, 3 puffs, 4 puffs. We in the process now designing a little device that emit a dosage that you can only take so much, but also you can just tap it on the back of your phone and it's got all the details. And you as the physician, you can actually top the doses or reduce or lock the device, which is exactly, so you can actually control it. So that's how far we've gone. And also another interesting point, what you mentioned about heavy metals and things like that. So us on the cultivation side, on the farm, we actually start that process to ensure that by the time you get to the bedside, you've got a clean product. So we actually test for all the heavy metals, for microbial activity, moisture levels, everything that is required. But thank you so much once again, the win-win platform, and very interesting about this association of yours that you've got. I think it's something that would also want from the continent, from Africa, to get also a lot of our clinicians on board. So I think that is wonderful. Thank you so much.
I would like to say, first of all, let us connect offline so that we can talk more about the association, but also this vaporizer, because I'm working with an interesting company and we're trying to find the right device that is internet connected to connect into some of the, to an EHR. And so let's talk about that as well.
Thank you. Our time is up. Global Health Catalyst, catalyzing care, research, and education. I'll give each one of you 1 minute, and I mean 1 minute, to wind up. But first, I want to start with Dr. Jordan, because there's a question for you, and then you wind up. Given the variation in composition of cannabis, how did the New Zealand study capture the variation? How many years did the study cover?
It didn't attempt to address variations or dosing or any of those sorts of things. So it was a study that took about 1,200 early teenagers in New Zealand, and simply has allowed them to use cannabis however they wanted to use it, and followed them now for, oh my goodness, it's 55 years. It started in 1970. So that's the answer. It's not looking to control any of those things. It's simply looking to see if any harms befell these users compared to the non-users. So that's, I think, the best answer to that question.
How many years did it take?
55, started in 1970. So, you know, that's covering most of the adults' lifespan of these young men. They were all, you know, sort of 12 to 14 years old when they started. So that would make them, you know, in their late 60s to early 70s now. So this is kind of the best ongoing study. And as I mentioned, they're still being followed. And I think that's fairly reassuring.
Dr. Flory, say a word to us, please, in winding up.
Thank you very much for all the presentations. So I really like our professor, I mean, like all the comments, also Professor Katerere comments, which speak to me as well, because you have a very huge population of pygmies, which are from the tropical forest, and really connecting to this community, the modernization of the science is key in our win-win collaboration to kind of improve translation of this phytomedicine drug into the clinic. Thank you very much, Dual.
Dr. Brillin, you can call Dr. Katerere to say one word and you finish with one word too, and then.
Oh, okay. Well, thank you very much. I've really enjoyed both speakers, great perspectives. And yeah, I'm really enjoying this series of lectures. So thank you.
Okay, Dr. Brillin.
Always a pleasure. Thank you so much. And I just want to thank the participants in particular, because they've made this happen. Without them, would not be talking to anybody at all. So this is really exciting, and I'm looking forward to more of these sessions. And we are reaching out. So this is part of an educational platform, which is great. So I'm sure each and every one of the people that I've participated in this session will impact on a million others as well. So I think let's continue, and thank you so much, Global Health Catalyst, for this wonderful platform and for this initiative. And of course, to the wonderful speakers we've had today, it has given us a new light to understanding it a bit more in detail as we move from the farm to the bedside. And thank you to everyone.
Thank you. Dr. Sandra.
Sure, thank you so much. Stay tuned. We still have 3 modules more, exciting information, more discussions to have. And thank you all for connecting. As Berlin said, for the audience, it's very important. This is going to be recorded in the YouTube channel of the Global Health Catalyst, and you're going to be able to see all the series. So let's keep moving the wheel, and let's see you in next Saturday. Thank you. Thank you, Jordan. And thank you,
Thank you,
Brilli,
all the
Dr. Katere. Thank you, Billy and Flori.
Thank you, all the panelists. If we say the Global Health Catalyst is undisputed champions in the research of evidence cannabis, I will not say much. I'll leave it there. Let history judge us. See you next week. Bye.
Bye.